All right, so if you guys haven't been here before in the past, this is what they consider a Zoom session. So it's going to be just an online webcam of me. I'm going over a quiz that I created on Kahoot. If you've never used Kahoot before, it is a app that basically you guys can log in and go ahead and answer the questions. So feel free to join us. All right, so let's get this thing started. Cardiology. So number one, your patient has obvious chest trauma. He is pale and diaphoretic. You suspect cardiac tamponade. What is the best treatment? A, needle decompression, oxygen, IV and transport. B, oxygen, IV, 500 ml bolus and transport. C, BVM, IV, vasopressor, transport. Or D, oxygen, aspirin, IV, nitro, and transport. All right. So only one person got it right. And let's talk about this. So remember, this is cardiac tamponade. It has nothing to do with a pneumothorax. So with a pneumothorax, we're doing a needle decompression. Remember, cardiac tamponade looks like this. All right. So it's basically a fluid that's filling around that pericardial sac that's around the heart. It's not allowing the heart to expand. The treatment of choice for the pericardial or cardiac tamponade is what? It would be pericardial centesis. Okay, so if somebody is to relieve that fluid out of the heart, it's got to be done with a special needle that's way longer than or I guess you technically could use some sort of needle decompression needles, not all of them. It's got to be a lot longer, and typically they'll go from underneath the sternum up towards the left shoulder while drawing back to try to get to release that fluid. Oxygen, IV, and transport, definitely, but 500 ml bolus. Remember, what's happening with that cardiac tamponade? It's not allowing the heart to expand, so what's happening at cardiac output? Cardiac output is being diminished. So increasing preload is something that is definitely effective. So we are going to provide that IV bolus. All right, next question. Number two, your 84-year-old patient is in asystole after 20 minutes of CPR. You ruled out the possible causes of arrest. What are you going to do next? Is it A, consider stopping of resuscitative efforts? B, continue working the arrest? C, transport while continuing CPR? Or D, you're going to defibrillate once more prior to calling online medical control? So your patient's in asystole for 20 minutes. All right. Not the easiest answer, just because C was a good answer, transport while continuing CPR. All right. In your book, remember, after 20 minutes of asystole, and this is the big one here. When you see this in your NREMT-P, you've already ruled out the causes of arrest. All right. How did we do so? We do that we're going to be ruling them out with our H's and T's. Once all that's done, we rule out everything with our H's and T's. We've been working this code for a long time. We've been giving epi every 3 to 5 minutes. Obviously, we can't shock this rhythm. We're just doing high quality chest compressions, continue ventilating. Remember, we have to call it at one point or another. Let's be honest, here in South Florida, if this is where you plan to work, there's hospitals every which way. So most likely we'd be doing the transport anyways, especially if we're working that patient. But how it's kind of coming down the hatch right now is that everyone's going to be staying and playing a lot longer on scene. That's supposed to be what's going to be considered the norm with cardiac arrest. All right, let's do the next question here. A chronotropic effect refers to one that affects the heart's what? Conduction velocity, contractile strength, its rate, or its rhythm. Chronotropic. All right, rate. So let's talk about this. Now, there's a medication that we give that works with chronotropic effects, but also with a couple other effects, all right? That medication is dopamine, right? So we have dromotropic, chronotropic, and inotropic. So you have to remember which each one means. Inotropic is contractile strength, okay? Remember, contractility. That is what inotropic is. Now, conduction velocity is dromotropic, okay? Dromotropic. And typically, when you give dopamine anywhere between from about 5 to 15 micrograms per kilogram per minute, you are increasing the heart rate and contractility by increasing chronotropic, inotropic, and dromotropic effects. All right. Jocelyn's killing it. All right, if your patient is experiencing a 10 out of 10 chest pain, but states that they get hives when they take aspirin, what are we doing? Withhold aspirin? Are we going to administer only one tablet of aspirin? Administer half the aspirin, or administer the full dose? And it looks like everybody got that one right. All right. Everyone got it right. So we're going to withhold aspirin if the patient has an actual allergic reaction to aspirin. Now, the biggest thing is one of the side effects of aspirin is actually abdominal pain or discomfort. If your patient states that they get abdominal pain when they take aspirin, we are not going to withhold aspirin. All right, we're only withholding aspirin when we have a confirmed anaphylactic reaction. If your patient states they get hives, they get shortness of breath, anything of that sort, we're not going to give them any aspirin. All right, good. During CPR, you note a pacemaker where you usually place your pads. How do you handle this situation? All right, A, we're going to call medical direction before proceeding. B, do not attempt to defibrillate. C, attempt to remove the pacemaker before starting defibrillation. Or D, continue CPR as usual and placing the pads away from the pacemaker, which everybody got right. Remember, this is a classic EMT question. You may also see something similar in ACLS. We never want to go ahead and put pads on pacemakers. There's a couple other key things when it comes to cardiac arrest. Hair. If there's a lot of hair, you do not want to place the pads directly on a large patch of hair because you need perfect pad to skin contact. If you don't get that, you don't just place your hand on the pad and make it tighter. You're probably gonna have to rip the pad off or shave around that area and apply a new pad. All right, another one's gonna be water. Water cannot be in between the pad and the skin, so you're gonna have to dry off that area. Jewelry has to come off as well. Good job. All right, workload of the heart is acutely affected by all of the following except what? Workload of the heart. The afterload, aortic capacity, the heart rate, or preload? A little harder of a question, but a couple people got it. So when we start talking about the workload of the heart, what's actually affecting this workload of the heart? Now, the reason why, remember, preload, heart rate, and afterload all affect the heart by increasing or decreasing its workload. But the aortic capacity, the width of the aorta, I know a few of you guys have heard me talk about this in the past. Your aorta is like the size of a garden hose. That capacity isn't going to fluctuate. All right, so that's not going to change. That's not going to change your workload of your heart. But everything else can change. Obviously, your rate can change. All right, your afterload and preload can actually change due to the amount of fluid that shifts, or the amount of fluid inside the pump. All right, so remember, aortic capacity ain't going to change. All right, your patient has been going to her scheduled dialysis. She has hypertension and pitting edema. What do you do, or what do you expect to see on that patient's EKG? So your patient hasn't been going to her scheduled dialysis. All right. So let's talk about this. Dialysis, hypertension, pitting edema. When we start talking about these kind of patients, obviously, if they're going to dialysis, this means they have renal failure. All right. Patient who isn't going to dialysis, typically they're going to be what is considered hyperkalemic. All right. Patients with hyperkalemia are going to have peaked T waves. Peaked T waves. Let me go ahead and pull up a peak T wave just to show you guys. All right, peak T waves right here. We can see, you see how pointy these T waves are. Not only are they larger than normal, but also it's that TP looking shape that those T waves are making. And that's considered peaked. All right. Now, whenever you do see peak T waves, that is typically, like I said, indicated for hyperkalemia. In the pre-hospital setting, we can give calcium chloride, all right? And a lot of the times we also will be giving sodium bicarb to these patients. The dose for calcium chloride is 500 milligrams to 1 gram, and the dose of sodium bicarb is 1 milliequivalent per kilogram. An 82-year-old male has chest pain. 12 lead reveals a left bundle, an ST elevation in V1 through V3. Which of the following is considered true? If the patient has history of bundle branch block, it's not concerning. B, a right bundle branch block masks normal interpretation of a STEMI. C, a left bundle branch block masks normal interpretation of a STEMI. Or D, bundle branch blocks, though concerning, do not affect the STEMI diagnosis. So this 82-year-old male has chest pain. This is what we see here on the monitor, okay? Left bundle branch block. We see some ST elevation, V1 through V3. Exactly like what I see right here. Good. So the only person who guessed the answer got it right. Now remember, left bundle branch blocks, V1 through V3, we are always going to have elevation. All right, that is considered normal. Now, when we start talking about bundle branch blocks, you always got to remember which one is which. Now, a lot of times people look at these bundle branch blocks and they think, man, my patient's having a STEMI just because they do see that elevation. But remember, every single bundle branch block that's considered left bundle is going to not only be wide, but it's also going to have a downward deflection in V1 through V3. So let's go ahead and pull up a couple of these EKGs that have left bundles. So left bundle, everyone could look straight at V1 through V3. Check out this one, V1 through V3. And what's crazy about left bundles is you can actually even find these in tachycardias, and some of them start to look really crazy because how long and how wide these left bundles are, it starts to kind of mask VTAC kind of. So, but remember, downward deflection and wide. So good. Now, one thing I did want to touch on is, again, Scarbosa's criteria. All right. So Scarbosa's criteria is something that we utilize out in the field to tell if my patient is having a heart attack when either they have a left bundle branch block or they have a paced rhythm. Now, like I said, a lot of the times you're going to have this patient, this one right here that we're talking about, they're complaining of chest pain. All right. You do the 12 lead and you get a rhythm that looks like this. All right. And the problem with this is you see all this elevation and you're like, man, is my patient having a STEMI? And you're reading the 12 lead and your 12 lead's even reading that the patient has a STEMI. All right. We're going to use something called a Scarbosa's criteria. Now let's take a look at it. This actually is pretty cool. This is, I think, the first thing that came up on Google when I typed in Scarbosa's, because you can even type it in here and the results will actually come up to tell you, yes, either your patient is meeting that criteria, they're having a STEMI, or they're not. Okay. So we got concordant ST elevation. Now, what concordant ST elevation means is anything that's concordant has a upward deflection of that QRS complex, right? So upward deflection with ST elevation greater than 1 millimeters and leads with that positive QRS, right? So when we look at something like, we'll use this one. Anything that has upward deflection, we take a look at. So we got upward deflection AVL. I got upward deflection in lead 1, and I got some upward funky beats going on here in V6, but nothing here has any type of elevation or ST elevation that I can note. So right then and there, this one, we're going to count that one out. Concordant ST depression, okay? ST depression and greater than 1 millimeters and V1 through V3. V1 through V3, do we have any depression in V1 through V3? No, we actually have elevation in V1 through V3, okay? Last one, excessively discordant ST elevation or depression and leads with negative QRS. Remember, so discordant, these leads are going to have a negative deflection in proportion to the preceding S wave or R wave, at least 1 millimeter of ST elevation. So this one is, I'm pretty sure it's supposed to be 5 millimeters. Elevation and depression. I don't like how this one words it. An easier one, because it's supposed to be excessive ST elevation, typically greater than 5 millimeters or more. And this one is actually worth the least amount of points. So one thing I don't talk about much is how much these are valued. All right. Now, if you look down here, it states in the original scarbosis criteria, a score of less than 3 typically is not considered a diagnostic acute myocardial infarction, but also does not rule out that the patient's not having an MI. In concerning patients, repeating EKGs and cardiac enzymes may be helpful, which they're going to be drawing those labs at the hospital. Now, when we do get this scarbosis criteria, if they meet either of these two on a call, these are typically like the big ones. The patient that has a acute MI and it is happening right then and there with a left bundle branch block, or like I said, a pace rhythm. There's a pace rhythm. Sometimes it's really difficult to tell. So not the easiest thing to remember, but just remember that you can always look this up really easily on Google. Scarbosis criteria. Let's move on. Unlike a second degree type 1 AV block, a second degree type 2 AV block is characterized by what? A progressive lengthening of the PR interval? Is it B, a ventricular rate less than 50 beats per minute? C, consistent PR intervals following conducted P waves? Or dissociation of P waves and QRS complexes? Remember, second degree type 2. All right. So remember, second degree type 1. Second degree type 1, everyone always calls it going, gone. Now, a couple other names, we got Mobitz 1 and we also got Wickenbach, right? Now, whenever you see a missing beat in any type of EKG, the first thing I'm thinking is this has to be a block. For me to confirm that this is going to be a block and not something like maybe a PAC or something of that sort, I'm going to go ahead and look at the PRIs or the PR intervals. Remember, your PR intervals are supposed to be not supposed to be greater than 0.20. And if I see any changes in those PR intervals as I look throughout that EKG, remember, whenever we look at an EKG, we're reading it like a book. So we're starting with the left and we're going to the right. While I'm reading that EKG, if I see any change in those PRIs, I already know it's not going to be a second degree type 2, because a second degree type 2 does not change those PR intervals following a conducted P wave or a normal P wave, it's consistent. Remember, these PR intervals are always going to be consistent with a second degree type 2. They don't change, but you're still going to have that drop beat. Now, don't forget that a second degree type 2 is actually considered a high degree heart block. So when we start talking about treatment, high degree heart blocks are actually treated differently than some other rhythms. And the only reason why I'm saying that is a lot of these second degree or high degree, heart blocks are going to be bradycardia. Your patient's going to be not only bradycardic, but they're also going to be hemodynamically unstable. So when I say hemodynamically unstable, your patient's going to have low blood pressure, and their heart rate's going to be less than 60. With that being said, I know a lot of people want to go ahead and jump the gun and just go ahead and give atropine. Remember, this patient, you can't just give them atropine. The reason behind that is atropine is actually going to keep those P waves going, all right? And remember, it's an AV block. So those P waves are going to keep going, and you're actually going to start giving more P waves, and it's actually not going to do anything for your patient except for increase their atrial rate, which can be definitely problematic. So the treatment for a patient in any high degree block, which is second degree type 2 or complete third degree block, is going to be pacing. All right, pace this patient. Number 11, what's a runaway pacemaker? Runaway pacemaker. Is it A, an absence of pacemaker spikes? Is it B, profound slowing of the heart rate? Is it C, a tachycardic pacemaker rhythm? Or D, a pacemaker that turned off? Runaway pacemaker. What is a runaway pacemaker? All right. Was it a profound slowing of the heart rate? No. Is it a tachycardic pace rhythm? Absolutely. All right. So you guys might see this one again. Okay. What is a runaway pacemaker? Don't forget, pacemakers are supposed to create a rate for that patient that is normal for that patient. So typically a rate anywhere from 60 to 80 is considered normal. So pacemakers are supposed to be set for those beats per minute. Now, if a pacemaker is considered a runaway, it's gone past that, so it's malfunctioned, and now it's beating at a quicker rate than what it's intended for. So it might be going over 100 beats per minute, and the patient doesn't know what's going on, and it's their pacemaker firing. Like I said, malfunction. Typically in these type of patients, we're going to take them to a facility that deals with pacemakers. All right, so they might need to get a new one or maybe even change the battery on it. That is a runaway pacemaker. A concordant precordial pattern exists when all QRS complexes A are less than 120 milliseconds, B greater than 120 milliseconds, C have a downward deflection in V1 through V6, or are upright in leads V1 through V6. Concordant precordial pattern. Concordant. I know I just used that terminology with our Scarbosis criteria. Was it a downward deflection or an upright deflection? Now remember, precordial, we're talking about V1 through V6 whenever we hear concordial or precordial leads, all right? V1 through V6. Now concordant and discordant, remember, our concordant and discordant is going to be upward or downward deflection. Concordant's always going to be considered upright deflection. So don't get those two twisted. Good. Now, when we start talking about 120 milliseconds, 120 milliseconds is the normal, or I guess less than 120 milliseconds is what's considered normal for a QRS complex width, right? So the width should be less than 120 milliseconds, or 0.12, less than 0.12 seconds. Good. Let's continue. A delta wave is identified on a cardiac rhythm strip as a apparent P wave that occurs at the end of the QRS complex, B, a delay between the end of the P wave and the beginning of the R wave? Is it C, slurring of the upstroke of the first part of the QRS complex? Or is it D, acute widening of the QRS complex immediately after the R wave? Delta wave. A delta wave is something that it's definitely not common, but a delta wave is seen in WPW, or Wolff-Parkinson's White syndrome. Now, the issue with WPW is that it can increase the patient's heart rate. All right. Typically, you are going to see, or with a delta wave, it's going to be a upstroke of the first part of that QRS. So I'm bringing it over here just to show you guys what we got going on. Let me find a good photo of it. I mean, this is kind of what we're talking about here. So when we start talking about a PRI or a PR interval, remember the PR interval starts from the beginning of the P wave and ends at this QRS complex. So what that PR interval is doing is we're allowing those atrium and the ventricles to fill with blood before we start those contractions, right? Now, what this delta wave is doing is it's actually decreasing that pause. Because we're decreasing that pause, like I said, this is going to cause a rapid heart rate. And what we do not want to do with this is we do not want to give medications that prolong those, prolong the AV node. Now, the reason being is that it's technically dangerous for the patient. Now, when I talk about prolonging the AV node, the medications that do so, one is adenosine. All right, that's the most common one that people talk about that prolong the or delay that AV node, the conduction through the AV node. So we're not going to be giving adenosine. And another one that we utilize is cardizem that actually slows that conduction through that AV node. We will not be utilizing cardizem either for this patient. The only medication that which I still think is kind of being researched, at least in our book, the Nancy Caroline book that still says that it's being researched, is amiodarone. If your patient's heart rate is greater than 150 and your patient is considered unstable, we are still going to be synchronized cardioverting that patient. But if we're going to be giving any medication for stable, one rate greater than 150 with a delta wave, we're going to be giving amiodarone. Or remember, it's going to be that slurring upslope right after that P wave. A regular rhythm with inverted P waves before each QRS complex with a rate of 82 is considered what? Junctional escape rhythm. B, ectopic atrial rhythm. Junctional sinus rhythm. Or is it an accelerated junctional rhythm? So remember, inverted P waves. All right, accelerated junctional. So now when we start talking about junctional rhythms, remember, when we talk about sinus rhythms, those sinus rhythms are starting where? The SA node. So it's going to be in your atrium. Normal heart rate for a sinus rhythm is anywhere from 60 to 100. This is technically considered normal. Now, junctional rhythms are starting at your AV node. Okay, so a regular junctional rhythm, also known as a junctional escape rhythm, I have right here in our book. All right, so our regular junctional escape rhythm is a rate from 40 to 60. That's a regular junctional escape rhythm, right? There's nothing that exists called a junctional sinus rhythm because remember, junctional is below that SA node is going to be in that AV node, so that doesn't even exist. Accelerated junctional is a rate that is 60 to 100. So nothing that goes over 100. This is considered accelerated junctional. And then once you go into junctional tach, that's something that is over 100 beats per minute. Now remember, these junctional rhythms do not have P waves or they have inverted P waves. Okay, so, and believe it or not, just even though it's coming from the SA node doesn't mean that we're going to have a downward deflection of that QRS complex. Remember, once that conduction does go from the AV node down into the ventricles, once with repolarization, that energy will go back to the AV node and at that point, we do get upward deflection of those QRS complexes. So don't expect, just because it's not a sinus rhythm, doesn't mean that we're not going to have narrow upward deflection on those QRS complexes, which can make it kind of confusing, but just don't forget, always, always, always look at the P waves, all right, when you're looking at a rhythm. Question 15, a right-sided EKG is indicated for patients who present with A, chest pain that occurs only during exertion, B, EKG evidence of an inferior infarction, C, elevation in the precordial leads, or is it D, chest pain that is unresolved with nitroglycerin? Right-sided EKGs. Good, so a right-sided EKG, don't forget, we don't do a V4R or any type of right-sided EKG. It's becoming a lot more common to actually take all of those precordial leads and actually putting them over onto the other side. If you're not doing that and your protocol allows for just V4 to move over to the other side, do so. And then all we're doing is looking at that V4 on our EKG. Okay. With that, let me see if this is one here. Yeah, I'm not the best of photos. But if I did do so and I was looking for a, again, terrible photos, I would only look in lead V4. If I redid this 12 lead on my patient and I put lead 4 over, I would go ahead and print it again, and I look over here at lead 4, and right here in this where I see vector 4, I do see elevation, and I'm going to call that a, not only is it a STEMI alert, but now we have right-sided involvement. Now, when you have right-sided involvement on an EKG, the issue with that is that our patient cannot be given any nitrates. All right. If you give them nitrates, you do have a chance of bottoming that patient out, and you will have some blood pressure issues. Okay. So right-sided involvement, the only thing that we can do is increase that patient's preload. The right side of their heart is really weak, so we want to go ahead and try to help it out by giving some fluids and not dilating those blood vessels. All right. Because like I said, we do not want to lower our patient's blood pressure more than it is. So we'll start with a 500 cc fluid bolus, and we will hang a bag of fluids. Remember, we can give up to about 20 mLs per kilogram of fluids. Just don't forget to listen to lung sounds. A lot of these patients can possibly be having signs and symptoms of CHF, or you might be hearing rails in their lungs. If so, you're going to be hauling butt to the hospital because you cannot give that patient any fluids. And if you do, just be very mindful that you might make it a little bit harder for them to breathe. So remember, this patient, we're going to be giving them aspirin. We're going to be treating them with fluids. Remember, we're only giving oxygen to these patients if they're hypoxic. We're not just giving oxygen to every single patient with chest pain, because remember, oxygen can also be, high doses of oxygen can also be considered a vasoconstrictor, and we don't actually want to reduce any of that blood flow to the heart or cause more damage or harm. All right, so good. Right-sided EKG is only indicated in inferior infarction. If you see any ST elevation in V1 through V6, we are not going to be doing a V4R. We're only doing that V4R for inferior wall 2, 3, and AVF on your EKGs. So 2, 3, and AVF. Right here, obviously massive heart attack here. They call these actually fire helmets. I don't know if you guys can see that. They call them the fire helmet. That's usually a really bad sign that they have massive elevation. So that's just massive injury to that heart. All right, next question. What is cor pulmonale? Cor pulmonale. Let's see who is actually reading their chapter. Is it A, left ventricular failure caused by systemic hypertension? Is it B, any condition that causes abnormal atrial depolarization? Is it C, I'll go back to your question. Sorry, Jocelyn, I just saw that. C, increased right atrial pressure caused by valvular dysfunction? Or is it D, right ventricular failure caused by pulmonary disease? core pulmonale. Good work, Jocelyn, my only person who's taken the test. It is right ventricular failure caused by pulmonary disease. All right, core pulmonale. Again, not something that we hear very much about. I feel like pulmonale kind of gives it away, that stems from pulmonary disease. But yes, and her treatment was oxygen and aspirin. Is that the only treatment? Was that for our right ventricular involvement? Was that what that question was for? So remember, it's mainly fluids. Aspirin and fluids is going to be our main treatment for that patient. We can also give some sort of analgesic, for example. Now, we want to kind of stay away from morphine, anything that can cause any vasodilation. Same thing like our nitrates. Now, fentanyl might be something a little bit better, but remember, fluids first. So we want to increase that preload, and we do want to give that patient aspirin first. All right. Number 17, we're almost at the EKGs. Other than O2, treatment for treatment for a patient with left ventricular failure includes what? IV, normal saline, 20 mLs per kilogram of fluid bolus, and a diuretic. B, saline lock and selective beta-2 adrenergic medication. C, an IV, normal saline to keep the vein open and nitro. Or is it D, IV of normal saline up to 20 mLs per kilogram? So other than oxygen, what is the treatment for a left-sided heart failure? Let's talk about this one. All right. So the reason why A was not the correct answer is because, well, nowadays, just about everything but that IV. All right. Normal saline is not given to a patient with left ventricular failure because when someone has left ventricular failure, that fluid that backs up from the left side of the heart is going to be going through those pulmonary arteries back into the lungs. And the issue with that is our patient's not only going to have shortness of breath, but our patient is also going to have fluid in their lungs. If I give more fluid to my patient with fluid in their lungs, you're actually exacerbating that issue. Be very, very mindful before giving any patient with fluid in their lungs fluid, because you can cause a lot of problems. Hence why we always, always, always check lung sounds before giving our patient fluids. Okay, so be careful of that. Diuretic medication, believe it or not, is no longer intended in the pre-hospital setting. All right. There was an interesting study that was done that basically said that there's too many variables when giving diuretic medications. They're not saying that diuretic medications are no longer given for patients with left ventricular failure. They actually are, but in the pre-hospital setting, we don't draw labs. So there's a couple of issues that we can cause by giving diuretics. So they kind of want that to be done in the hospital. In the pre-hospital setting, we're going to be starting an IV. Whenever you see normal saline, keep vein open. All they're saying is that we're giving that fluid extremely slow just to keep that vein open so it doesn't clot. And that's it. We're not actually giving this patient fluids. This could be one drop every 6 to 10 seconds. You know what I mean? So it's just very slow drips just to keep that vein open. And don't forget nitroglycerin. All right. This patient requires CPAP and nitroglycerin. Those are the two things that are going to save this patient, CPAP and nitroglycerin. But don't forget, your patients with left ventricular failure can also suffer from anxiety. All right. And if the patient is anxious and they have that CPAP on and it's not working out for them, we can always give them a benzodiazepine to assist with helping them relax. We're not trying to snow the patient or knock them out, because if doing so, you're going to be intubating them really soon. So let's try not to do that, but we want to go ahead and help them relax. So if you do want to give maybe a couple milligrams of Versed, that's okay depending on the size of the patient. Maybe a little old or elderly patient, you don't want to give them 2 milligrams. Maybe you want to even start a little bit lower than that. Now, why don't we want to give a beta-2 adrenergic medication? So beta-2, remember beta-2 does what? Bronchodilation. Now, we don't really have an issue with bronchoconstriction with left ventricular failure, do we? Not really, all right? Actually, not at all. We don't have an issue with bronchoconstriction. We have an issue with fluid, okay? So now we got fluid that's backing up. Now we're dilating the blood, the bronchioles. Giving a beta-2 adrenergic can actually even, I've even heard it cause problems. We can actually flood the patient even a little bit quicker. So let's not do that. We just want to give nitroglycerin to kind of lower that blood pressure. Now remember, if that patient's blood pressure is too low to give the nitrates, now we can't do so, and we're going to be treating with dopamine. Remember, we're not giving this patient fluids. But no, that's a good one. Number 18, what does JVD in a patient sitting at 45-degree angle suggest? What does JVD in a patient sitting at a 45-degree angle suggest? It indicates right-sided heart compromise. B, a sign of reduced preload. Is it C, suggests left-sided heart failure? Is it D, it's not clinically significant? So right here is our jugular vein distension. Good. Indicates right-sided heart compromise. Now, whenever we want to go ahead and check for JVD, we want to do so at 45 degrees. All right, you do not want to check for JVD when your patient's laying flat, because understand that JVD is actually common and normal if your patient's laying flat. If your patient's just hanging out, chilling, and you're at 45 degrees, they should not have jugular vein distension. And if so, this can indicate right-sided heart compromise. Now, typically, patients that have a form of obstructive shock, so a late sign of tension pneumothorax can cause this right-sided compromise, because remember, that lung could be pushing against that mediastinum and actually pushing pressure on that right side of the heart, not allowing that heart to fill with blood. Then that pressure will cause this JVD to distend. Also, a very common one would be cardiac tamponade. But good, right-sided heart compromise with JVD. On the 12 lead, right atrial abnormality is characterized by what? So on a 12 lead, right atrial abnormality. Right atrial abnormality. Is it A, negatively deflected P waves in lead 2 and V1? Is it a P wave amplitude greater than 1.5 millimeters in lead 1? Is it a P wave duration greater than 110 milliseconds in lead 2? Or is it a PR interval greater than 200 milliseconds? Atrial abnormality. All right, so one person got it. P wave amplitude greater than 1.5 millimeters. All right. Right atrial abnormality in V1. So V1 is, remember, when we start talking about right side, typically how the EKG is set up, remember, it goes across the left. V1 is the only one that's actually technically on the right atrium when you think about where those limb leads are placed. So be mindful that when right atrial, typically they're talking about lead V1 or vector 1. Any P wave amplitude that's greater than 1.5 millimeter is considered an abnormality. You might see that again, maybe on a test near you. Number 20, door to balloon time for a patient with ST elevation. Myocardial infarction is what? So door to balloon. This guy's inserting that cath. Is it 90 minutes or more? Is it 90 minutes or less? 60 minutes or more? Or 60 minutes or less? Remember, this is door to balloon. So that means ER door. not you to the patient's door, the patient, when they hit the ER door, to balloon time, meaning that the doctor's already inputting that balloon. How much time does American Heart allow these hospitals to have? 90 minutes. Okay, this is a classic ACLS question that you can definitely potentially see in your NREMT-P. Door to balloon time is 90 minutes or less. Okay, it actually seems like a long time, right? You might be like, damn, it take them 90 minutes from ER door to actually getting cath. I think most hospitals are doing it a lot quicker than that now, but that is kind of the guideline that the American Heart allows or released. All right, let's get into some, just checking here, let's get into some EKGs. All right, let's see how you guys do. Interpret these EKGs. First EKG, is this a first degree block? Is it a second degree type 2 AV block? Is it a complete heart block, or is it a second degree type 1 AV block? So here we got a complete heart block. Let's go ahead and show this photo again. A little blurry, but let's talk about it. So when we start talking about blocks, especially if you look at the answers and you're like, oh my God, it's just a ton of blocks. First thing I'm going to ask is, okay, is there any drop beats? That's the first thing I want to know. Because if there is drop beats that I see, there's only two answers that could be. It's always going to be a second degree type 1 or second degree type 2. If there's no drop beats, I'm now going to ask, okay, is there consistent P waves? And are they long in length? All right, so there are consistent P waves, actually a little too consistent. There's too many of them. The only one here, well, here and here and here, they're kind of long. I would be like, oh man, if they all look like this, I would consider that a first degree block. But because there's so many P waves in here and there's not that many QRS complexes, all that means is that the QRS complexes or our ventricular depolarization is not the same time frame as our atrial depolarization. And with that being said, it's a complete heart block, a third degree block. Now remember, these P waves, when you start measuring our distance from these waves, they're always going to line up. All right, so the distance between each one is very similar. All right, and if you ever take two pencils and you put them on two P waves, you should be able to move that over and they'll always line up. Same thing with these R waves. So these QRS complexes, we can even see from here, they're on the same row. All right, so like I said earlier, this is considered a high degree heart block. With high degree heart blocks, remember, we treat these patients with pacing. We are not going to give this patient atropine. Question number 2, another EKG. What do we see here? We got a 12 lead. Do we see an inferior wall MI, anterior septal MI, anterior lateral MI, or do we see a septal MI? What kind of MI do we have here? Oof. So let's take a look at this. We got depression in the inferior leads. Remember, when I'm talking about an MI, I'm looking for a STEMI, right? I'm looking, is there any elevation in this 12 lead? So the first thing I'm going to do, I'm going to read this thing from left to right like I do every EKG. I'm looking down here. I start V1, V2, lead 2. I see, okay, I got some depression here. Remember, depression means ischemia, right? Now I'm looking over here in the precordial leads. We have some massive elevation. I got elevation of V1, V2, V3. All right, V4, it's kind of funky here, but definitely V1 through V3, right? Massive elevation. And I actually have some depression here in V5 and V6. But remember, this means injury. When I have injury, my patient is having an MI. ST, elevation myocardial infarction, is known as a STEMI. These are reciprocal, right? Reciprocal changes that I'm finding in leads 2, 3, and AVF. So be mindful. This is an anterior septal MI. Remember, septal and anterior. Interpret the next EKG. All right, we got another 12 lead here. Do we see a right bundle branch block? Is this another anterior septal MI? Do we now have an inferior wall MI, or do we have a left bundle branch block? This one's a little funky. Let's talk about it. All right. So I know we had a question on this earlier in the multiple choice test questions. Whenever you see anything that is wide and down, wide and downward deflection, and we have elevation here in leads V1, V2, V3, we even got elevation here in V4. Remember, wide and down, think of left bundle branch block. Now, I remember telling you guys before, like your clicker, your turn signal in your car, when you're making a right, you go ahead and push that turn signal up, right? So when you have that upward deflection and bunny ears, right, or those terminal R waves that you're going to be seeing in lead V1, that's considered a right bundle branch block. Now here we have the opposite. When you go in and turn your turn signal down, we have downward deflection, wide QRS complex. This is considered a left bundle branch block. And believe it or not, when you have a patient with a ventricular pacemaker, it looks very similar here to these left bundles. But obviously the only difference is you're going to have those pacer spikes, hopefully. All right, if you're not sure, you can always ask the patient if they have a pacemaker, or you can, if they're unresponsive, you can always just look under their shirt and look for a pacemaker yourself, okay? But you got to be able to call those left bundles. Number 24. Interpret this EKG. Is this a normal sinus rhythm? Is it a first degree AV block? Is it a second degree type 1 AV block? Or is this a third degree AV block? All right. Let's take a look at it again. For whoever put a normal sinus rhythm, understand this is not a normal sinus rhythm. Why? Because the distance of these PR intervals are too long. Remember, if it's greater than 0.20 seconds or 200 milliseconds, it's not going to be a normal sinus rhythm. All right. And remember, each one of these little tiny blocks is 0.04 seconds. So in 5 little blocks, starting from here all the way to here, if it's greater than 5 blocks, that's considered a first degree AV block. Okay. So remember, each little block, each little box right here, that's 0.04 milliseconds. I'm sorry, 0.04 seconds. So 5 of these little blocks, which is right here, and this one big box that we can see, right? That is right there. That alone is considered 0.20 seconds. So starting from right here, and which I like this one right here because it's actually on the line, starting our PRI, right? So our PRI should not be longer than right here to right here. But this one is about half of another large box. So it's considered delayed or longer than normal. So that's our first degree block. Typically in our first degree blocks, this is something that we're not, especially in the pre-hospital setting, this is not something that we're worried about. But you can always let them know when you get to the hospital. Number 5 on EKGs. What's this rhythm? Is it considered sinus arrest? Is it a wandering atrial pacemaker? Is it AFib or is it VFib? Let's take a look at it. Now, you might say, wow, this thing looks crazy. VFib might even pop up in your head because how much chaos I see going on here. But understand that it's not VFib because we have these QRS complexes, right? Now, this rhythm is considered irregular which makes it AFib. All right. The R to R's are not the same, even though this one kind of looks very similar to this one. But remember, it's supposed to be just sporadic. It's also atrial in nature, meaning that we have that upward deflection, and also it is narrow QRS complex. But yes, this is atrial fibrillation. Now, the problem with atrial fibrillation is new onset of AFib is a common cause for strokes and clots. Hence why your patients that have AFib are typically on medications such as blood thinners, or they might even be on a medication called digoxin, which can regulate that heart rhythm. Now, that medication, digoxin, a lot of people call it dig. The problem with dig is that it can cause a fast heart rate. If it does, be careful on how you treat dig toxicity. Believe it or not, most newer, we got to really look at it in our book. We're going to get to toxicology soon, so I'm not going to jump ahead, but I know out in the field, we're actually doing low dose synchronized cardioversion for dig toxicity. Now, like I said, digoxin is one of those medications that patients with atrial fib and even CHF are taking. So you might see that in your elderly population, or those patients that have heart problems. Number 6, EKG interpretation. What is this EKG? We see it's fast. Is it sinus tach? Is it supraventricular tachycardia? Is it accelerated junctional rhythm? Or is it V-tach? You are right. It is definitely SVT, right? Supraventricular tachycardia. I know this is coming from above those ventricles. Why? Because it is narrow. These QRS complexes are narrow. We do have that upward deflection. Now, it's so fast that the P waves and the T waves are actually getting smushed. I can't really tell. I'm guessing this is a T wave and that's the P wave. So they're I could kind of tell which one's which if I were to guess. But remember, this rate is going to be over 150 and greater. I've seen SVTs go over 200. So be mindful of that. Now, remember, the treatment for SVT is going to be adenosine, right? So if your patient is stable, we're going to be starting with 6. We can go to the 12. After the 12, we can consider a beta blocker. We can consider our calcium channel blockers such as cardizem. And if our patient becomes unstable at any time, we can go ahead and synchronize cardiovert this patient. Just remember, if you are going to synchronize cardiovert your patient who is conscious, please give them some sort of sedation, preferably something that's fast acting, such as a tamponade, just so you can drop them pretty quick and you can synchronize cardiovert them and they won't hate you for it. So hopefully you're carrying a tamponade. If not, you're going to be giving something like Versed or, ketamine or something of that sort. Could take a little bit longer to act. Next, EKG. What do we got here? Do we have torsades? Do we have AFib? Do we have coarse VFib, or do we have fine VFib? Tricked you. I put that answer there just because I knew someone was going to go for it, because you see right here, you're like, oh my God, it's really big, then it gets small, but then we get chaos. All right, so this is coarse VFib getting finer, right? So when we get chaos here and it gets smaller and smaller and smaller, even this right here, we'll consider that coarse VFib. Fine VFib looks very much like asystole, very close. There's just a little bit of what kind of looks like artifact, but that would be more considered fine VFib. If you see anything that looks really erratic like this, or especially like this, that's considered coarse VFib. Now, remember, torsades would be big, small, big, small. It wouldn't get smaller in size, like all the way down. It's just going to go big and then smaller and then big and then smaller and then big and then smaller. And it's going to keep doing that same pattern. And that is torsades de points. So don't get those mistaken. Another EKG here. What do we have here? Is this sinus tach? Would this be considered a flutter? Is it AFib, or is this accelerated junctional rhythm? Everyone always gets this one right. All right. It's like one of those rhythms that we don't see very often, but it's so like distinguished in your mind that you're not going to get this one wrong. All right. These sawtooth patterns are what we're looking for when we start talking about a flutter or atrial flutter. Now, remember, it's giving it away, right, in the name, atrial flutter. So what's happening with this patient? Their heart and the atrium, or the top part of their heart where the SA node is conducting this pulse, it's going way faster than the ventricular's rate, right? So we see these ventricles firing in our QRS complexes. But what do we see here? How much faster is our atrial rate right now than our QRS's? A ton faster. Okay, so we need to slow down this rate. The medication of choice is going to be your calcium channel blockers. Okay, so cardizem will be my drug of choice if I see a flutter. Now, when you look at this heart rate, you might even see a heart rate and you're like, oh man, it's only at a rate of 80, but really is it at a rate of 80? It's actually not. Okay, like I said, these atrium are firing extremely fast and we need to slow that down. Like I said, we'll use something like our cardizem or diltiazem. Verapamil is another calcium channel blocker that you might be hearing. Can you give adenosine? It won't hurt the patient, but it's not going to be effective. All right. I've read a couple articles on that have been tested. Calcium channel blocker is the drug of choice for a flutter and RVR. So when I talk about RVR, I'm talking about rapid ventricular response with AFib. So when you have AFib that is going over a rate of 150, and you'll see it, because remember, AFib is going to be sporadic, right? So you're going to see maybe a rate of 120, 138, 162, then it goes right back down to 110, 148, 178. So it's fluctuating. As long as that fluctuation is going above the rate of 150, I'm considering this RVR, a rapid ventricular response, and I'm going to treat that with a calcium channel blocker. All right, my cardizem. First dose, 0.25 milligrams per kilogram. Second dose, 0.35 milligrams per kilogram if needed for those two EKGs. Good job. Number 29, interpret this EKG. What do we got here? Is this a third degree AV block? Is it a second degree type 1 AV block? Is this a second degree type 2 AV block? Or is this sinus arrest? What do we have here? Good. Second degree type 1. Now, what you're looking for in this rhythm is you're going to be looking, like I said, whenever you see a drop beat, immediately in your head, you need to say to yourself, okay, I got a second degree block here. Next thing I'm going to look at is my PRI, or my PR intervals. Remember, our PR interval starts here at the beginning of our P wave and then at the start of our QRS complex. Now, if these PR intervals remain the same every single time, we know it's a type 2. If they change, meaning it gets small here, it gets a little bit longer here, it gets even longer, that's going to be type 1. So second degree type 1 is what you have here. Going, gone, Wakenbach, or Mobitz 1. Good job. And our last EKG for the night. What is going on in this 12 lead? We got some funky little beats here. Is this an inferior wall MI? Do we have a left bundle branch block? Do we have a right bundle branch block? Or do you see a septal MI? Let's talk about it. So when I go ahead and look at this 12 lead, like I said, I'm going to read it like a book, right? So I'm going from left to right. Let's look at 1, 2, 3. I'm already seeing some funkiness happening here, right? The second I start seeing these terminal R waves on my EKG, are also known as bunny ears, right? I'm going to say, okay, upward deflection, bunny ears, technically considered wide QRS complexes, all right, here in V1. Classic right bundle branch block. Right bundle branch block. Remember, this is not elevation. The reason why this is not considered elevation is because we have, first of all, this is like a terminal R wave, so it's showing two separate R waves, right? Or small little tiny QRS, even right here. Look at this QRS, and then goes right back into a QRS. Now it's not, it's coming right back down to this isometric line, right? It meets right here. We also got starting right here, and same thing over here. So I don't technically have any ST elevation to note. I don't even see any STL depression anywhere. I was kind of thinking that I had a little bit of depression here, but I don't think so, not really. So this is classic right bundle branch block. Remember, with the right bundle branch block, it's going to be upward deflection with terminal R waves or bunny ears. Let me go ahead and pull up some right bundle branch blocks just so you can see how crazy they're all alike, very similar. All right, so let me open up one right here. Terminal R waves right here, upward deflection. Terminal R waves, upward deflection. Terminal R waves, upward deflection. Terminal R waves, upward deflection. You see what I mean when I start when we start talking about these bundle branch blocks? They're always going to look alike. You just got to know what you're looking for whenever you see them. So between right bundle branch block and left bundle branch block. So if I go ahead and put in left here, remember it's going to be widened down, right? So if I look at an EKG here, wide QRS complex, downward deflection, wide QRS complex, downward deflection, wide QRS complex, downward deflection. And these are all different EKGs, right? But they all look identical when we start talking about our bundle branch blocks. So don't get them mixed up, please. If you're still here, thanks for watching. I plan to be making more of these videos, and I wish you guys the best of luck in studying for the exam. If you have any questions, please, as always, feel free to ask.